So should I start? Bismillahirrahmanirrahim. Assalamu alaikum and good morning to all the respectable guests. And I'm really thankful and I welcome all. आपका बहुत शुक्रिया कि आपने वक्त निकाला अपने कीमती टाइम से और हमारी इस प्रेजेंटेशन के लिए हमें ज्वाइन किया. For recitation, I would request Dr. Ahmad to come on the stage.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم أرأيت الذي يكذب بالدين فذلك الذي يدع اليتيم ولا يحض على طعام المسكين فويل للمصلين الذين هم عن صلاتهم ساهون الذين هم يراءون ويمنعون الماعون صدق الله العظيم.
Now I would request Professor Dr. Uzma Hamza to please come on the stage and deliver a welcome note.
Assalamu alaikum. Welcome to all respected guests. I'm really thankful for your time. Basic concept of this talk with Dr. Nabeel is because myopia has become a global threat, a global concern because there is a rapidly increase in number. There is early onset of myopia. और हम अपनी डेली क्लिनिकल रूटीन में हम देखते हैं एवरीवन इज आस्किंग हाउ टू प्रिवेंट द प्रोग्रेशन. पेरेंट्स हमसे पूछ रहे होते हैं, पेशेंट पूछ रहे होते हैं कि हाउ टू प्रिवेंट द प्रोग्रेशन. So main reason for arranging and requesting the Dr. Nabeel Ahmad to give the innovative some methods or measures which can use for progression, decrease the progression of myopia. Myopia WHO के अगर हम देखें तो वो according to WHO by the 2050 half of the population of the whole world will become myopic. हमारे पाकिस्तान के प्रोस्पेक्टिव में हम देखें तो हमारी वास्ट मेजॉरिटी जो रूरल पॉपुलेशन है उसमें स्कूल गोइंग बच्चों के अलावा मदरसा बच्चे भी हैं, उनको हमने इग्नोर नहीं करना. वी हैव टू स्टार्ट अ कोलैबोरेटिव एफर्ट जो कि हम सोशल मीडिया के साथ बीइंग डॉक्टर और साथ में हेल्थ वर्कर्स बाकियों के साथ मिलके हमें उन्हें भी अपने लूप में लेना है. टुडे वी आर taking a step for our self education कि कैसे innovative methods कौन से हैं जिससे हम myopia progression कम कर सकते हैं. As far as ophthalmology department of Jinnah Hospital, हमने इससे पहले भी कोशिश की है कि ऑनलाइन भी डिफरेंट हम गेस्ट को बुलाएं, जो कि नदीम हफीज़ भट्ट साहब के दौर में ऐसे होता था। हम गेस्ट लेक्चर्स के लिए डिफरेंट स्पीकर्स को बुलाते थे और नई इनोवेटिव चीज़ें जो हैं उसको हम अपने स्टूडेंट्स के साथ भी और बाकी ऑप्थेल्मोलॉजी टैलेंटिस्ट के साथ शेयर करते थे। इस इंशाल्लाह जो स्टेप था इसको हम कंटिन्यू रखेंगे। एंड आई विल इनवाइट नाउ द डॉक्टर इरफान
Thank you, Dr. Usman, for your sweet words. I would request my worthy guests on Zoom that if they can hear me clearly, please give thumbs up in your in person in messages. A brief introduction to Dr. Nabeel. Dr. Nabeel Ahmad, I'm really thankful that you have spared some time for today for us. And Dr. Nabeel has done his MBBS from Aga Khan University. He has done FRCOphth. He has done his PhD in Vision Sciences from National University of Singapore. He has done fellowship in Glaucoma, fellowship in Medical Retina, and fellowship in Uveitis, again from National University of Singapore. He has done a fellowship in complex cataract and advanced anterior segment reconstruction surgery. And I've already mentioned that he's PhD in Vision Sciences. So today he's here to enlighten us about the recent advances in to stop the progression in myopia, which are and international practices which are being followed worldwide. So I would request Dr. Nabeel to let's start this discussion.
Guru, you guys can hear me? Oh, okay. Just let me know if you guys cannot hear. Okay, so Bismillah. All right, so Dr. Irfan briefly first of all, I'm really thankful to everyone over here. This is extremely humbling for me to, overnight become an expert and give a talk. I've never done this. So I love teaching, but it's always been to residents or fellows or to other colleagues. So, this is really humbling for me. And I'm extremely thankful to this department, to Professor Hamad Batsab, who I recently met, and to Irfan and Dr. Kashif and everybody and every single body. I'm in the presence of all the living legends here, and I've heard so much about him, from Dr. Azam Ali. So after my graduation, I worked within Pakistan. I worked with Dr. Azam Ali for the longest time, and he's the reason why I pursued ophthalmology. So yeah, okay. Then I went abroad and worked with some of the living great giants of whatever fields they are in, be it glaucoma, be it medical retina, be it uveitis, complex cataracts. It was literally just by chance. I did not plan on doing any of that. So anyways. Okay, so coming to this talk, before we kick off, I would like to put a question out to everybody. There's a reason why every one of us is here. And the reason that connects us all here today is because somehow, one way or the other, we are all connected with human vision. And every one of us is somehow concerned with preservation of human vision and human sight. That's very humbling in itself. So, with that, it's something that connects us. Doesn't matter if somebody is the head of the department who has given his life to this, and doesn't matter if somebody is just kicking off. Doesn't matter if somebody is kicking off. And next slide. Okay, yeah. And doesn't matter if somebody is kicking off his career in this. This is something that connects us all. This preservation of human vision. We all love doing cataracts. We all, love getting rid of our glasses for our patients. But it's more than that. Ophthalmology is more than that. Human sight is more than that. And that's the reason why we're here. Myopia has become this threat. Okay, so the first part of this talk is about myopia. What the problem is, where we stand today, from an academic point of view, from a research point of view, from an understanding point of view. And the second part of this talk, after the break and everything, is about what we can do to fix it. So this is how I've raised this talk. If anybody wants any references, I would be more than happy. There's a recent publication by National Academies Press from America, and basically most of this talk is just designed along those lines. And the target audience for this is like trainees, colleagues, people who practice comprehensive ophthalmology, and public health people. So okay. Now, talking about global prevalence. Before I talk about the prevalence of myopia per se, I would like to talk about human population. Over the last few centuries, we have human population on this planet has really increased. If you just look at this graph, let me see if this works. Next slide, please. Okay. Can you blow it up? अच्छा चलो ठीक है, it's fine. ठीक है. Okay. If you look closely over here, over the last few centuries, वो view रहने दे जी, that's fine. Yeah. So if you look here, all the way from the last few centuries, the human population keeps on increasing, doubling, more than doubling. Now the current projections say that by next century, that is 2100, and maybe around 2100, this first couple of decades, we won't be living that day. So by that time, the human population will plateau. That is about when the population of this planet would be around 12 billion. It is currently 8 billion. It would be 12 billion, and then the growth rate and the death rate, it just equalizes. So that's the point when human population plateaus. That's a huge number. Currently, as we stand from a population point of view, India 1.5 billion, China 1.5, America, Philippines about 350 million, and then comes Pakistan. It is projected by the end of this century, definitely the later half of this century, and definitely by the next century, Pakistan will be the world's third largest country by population. It will be the world's largest Muslim population country. That's a huge thing. Those are huge numbers. Most of us will be just doing clinical practice for maybe next couple of decades. By 2050, most of us would be retired. People definitely in this room. Some might make it to 2060 or even maybe 2070. But the point is, what we do today as clinicians, from a public health perspective, it's going to resonate through our generations, and we need to think about that. So that's the thing. As our esteemed professor just mentioned, it was in 2016 when Brian Holden Vision Foundation, in collaboration with World Health Organization, they came up with the data and they said that myopia will be, half of the world will be myopic by 2050. This was only one fourth. When this century kicked off, the numbers were only one fourth, 25% roughly. Right now, it's one third. The current data estimates that in 2025, every third guy is myopic. Obviously, there are nuances to this fact, but that's just the way it is. So we need to talk about national eye health. There is a concept of very solid and robust concept of global eye health. But we need to talk about national eye health, because when we have, as a clinician, as an academics under this roof, when we have this concept of national eye health, we can advise our policymakers. In Pakistan, unfortunately, people become doctors, but those doctors don't really go and take public health positions the way they should. That's not how it is done over there. Over there, currently the developed world, certified clinicians, they eventually later half of their life, they just take up public health as their lifelong careers. And we need to do that, because nobody understands these problems better than a clinician. Somebody who sees 20 patients a day, 100 patients a day, somebody does routine cataract, stuff like that. Next slide, please. Okay. All right, so I'm going to talk about 3 robust studies just to give you a current idea. None of these studies from Pakistan, obviously, but it gives us an idea that where the world is heading towards from a prevalence point of view. So this is a Chinese study, and if you look closely, you can see that there is a continuous increase in the prevalence of myopia. Doesn't matter if it's urban population, doesn't matter if it's rural population. Over the last 2-3 decades, it's constantly increasing. It's constantly increasing. And during the pandemic, there was even more increase in the urban population. Okay, next slide. All right, this is an interesting study. I would not talk about the part that is a bit conflicting in the study, but it's a robust study, so that's why I'm mentioning it here. This is a study done in Canadian and Scandinavian population and Inuit population, and if you look at the prevalence of myopia, it's found that it is in the young population. It wasn't the case long ago. This last part of this graph is a bit conflicting, and because the researchers thought the data is not accurate, so that's why I would just focus over here. Most of the people with myopia are in their youth. Okay, next slide. All right. This is also an interesting study. It is another from a developed world. It is from Australia. And this study shows that even though it's a developed world, and we have seen this increasing trend of prevalence of myopia across the world, all over the world. But that's not the case with Australian population. If you see, the trends are going down. Doesn't matter where they did, how they did, and they even compared it against with UK population as well, and they found that okay, it's not like that. We'll talk about the reasons for that. Next slide, please. All right. This is a study from Israel. I know we hate Israel, but just because this is an academic environment, so we can talk about this. Now, in Israel, everybody joins military. It's just the way it is. Doesn't matter if it's a guy or if it's a girl, they all have to join and they all have to serve and they all have to do their part in the military. A couple of years ago, there was a rule that doesn't matter, regardless of people who are not pregnant or who are married, or people from some ethnic minorities, even the scholars, they are called ultra orthodox. We can, relate that to our religious madrasa, which doctor was alluding to in the beginning of the talk. They also joined. Now, can we go to the, yeah. Anyways, so the scholars, which usually don't work in the military over there, they also joined. Now, what they found was really interesting. They found that the scholars of the Israeli population who never joined military before, when they joined, so their vision was screened. And when the vision was screened, yeah, okay. So when the vision was screened, they realized the incidence and the prevalence of myopia was way more amongst those compared to the normal population. By normal, I mean the rest of the society. This was an interesting fact for them. And then when they really looked into it, they realized, oh, they start studying early. They spend time outdoors much less than compared to the rest of the population. Why? Because these scholars have a very high demand from an academic point of view. They have to learn multiple languages and everything. So this is really interesting data because it's very robust. And then this, changed these guidelines, and the scholars didn't have to join and work in military later on. So this data really, put it out over there on the perspective that, okay, something is going on here and we need to figure it out and we need to tackle it. All right. So everybody knows that what is myopia, okay? And there are many types of myopia. I'm not going to go into detail just because I assume everybody understands these things. But so there's axial myopia, there's corneal myopia, there's lenticular myopia. This talk is basically focused on so-called axial myopia, right? I will discuss briefly towards the end of the talk what is the role of astigmatic or corneal myopia, right? But most of this talk, most of the discussions, most of the prevalence, most of this hype and everything that's going on all over the world, it is about axial myopia, the elongation, anterior posterior elongation of the eye. Now, when a patient comes to us, routinely in the clinic, we have all these things. Next slide. You have the next. Okay. We take the history, we do the exams, we take the photos, we do the biometries, we have the OCTs and ERGs and contrast sensitivities and visual fields. Now, most of the times, the problem is myopia does not get picked up when it should. It becomes very challenging, especially you're in pediatric population. Kids don't complain. They don't say that, oh, I cannot see clearly, especially the non-verbal kids. So it becomes very challenging. One has to ask the specific questions. These days, people don't even use television the way they used to use it even 1 decade ago, even 2 decades ago. Previously, parents would just come to us in the clinic and they would say, "Oh, Dr. Saab, mera bacha nazdeek se jaake TV dekhta hai. My kid cannot see, look at the TV clearly from far." And that's a clue. We would pick it up. That's not the case anymore. 6-month-old, 1-year-old, 2-year-old has his own smartphone and he's just looking at it the whole day. He will never complain he cannot see, right? And if he's playing games, the games are also at his cell phone. So we really have to be on our toes to be on the lookout for picking up myopia. We have to ask the questions. Have you noticed this compared to other siblings? Have you noticed this compared to other cousins? Have you noticed this? As a clinician, it becomes mandatory. Most of us have very busy practices, especially the ones in government settings, even the ones in private settings. Pakistan, in country like Pakistan, everybody is overworked. It's easier said to, it's easy to say, stand up here and say these, make these recommendations, but it's much harder to do it in everyday clinical practice. But that's just the way it is. All right, so we have to be on the active lookout to ask the pertinent questions. Second comes is the standard eye exam. Now, we'll have the discussion about these towards the end of the talk as well. Most people, when they look at the kids, first of all, people don't like examining kids because it's just tough and challenging. And the reason for that is it's time consuming. Kids don't behave the way adults behave. And it's very hard to get an accurate vision out of a kid. especially a non-verbal kid, especially somebody who's even old, younger than 3 years or 4 years of age. And then if you want to cycloplegic them, it becomes all the more challenging. So, and if we want to sedate them with chlorohydrate, we need to have certain protocols. We need to have the pediatric nurse and everything. So these are nuances. These are everyday nuances. They can be easily tackled in an academic institute of this caliber or from a tertiary care point of view, but it becomes much challenging to do that in a small private setup or even in a rural setting. So history and examination are the first and foremost to pick up myopia, to pick up refractive errors. This talk is totally focused on myopia, especially axial myopia, but it's just out there. All right. So all over the world, many academic institutes with research backing, they have started implementing these things. The first four, and some centers even the first five things, if I have to, really count it in. What they do is they do serial photography, fundus photography. It has many benefits. There are many platforms from industry partners which take very reliable pictures, and these pictures can be serially monitored. The good thing about this is we were going to talk about artificial intelligence and teleophthalmology at the end of the day, towards the end of the talk in the second part. That's where this becomes really important. Artificial intelligence, teleophthalmology, they work on data sets. We need to train it. For training and for that data set, we need to have data. The only way we can have data is by taking these pictures and photographies and all of that. All right, everybody knows we can do all these OCTs and everything. The one point that I would like to make here is most OCT, I haven't seen a portable OCT in Pakistan yet. I have to see one. So a lot of times it just makes our job much easier. So, and there are many democratized versions of OCTs now, and they're not that expensive. They even give a good scan of up to 7 micrometer, so which is pretty, reasonable. So that's that. ERG has not made its way all the way into clinical practice. It's anything other than routinely speaking inherited retinal diseases, but there is evidence that it affects the on pathways. We'll talk about that later. And contrast sensitivities, most of us, I strongly believe, and a lot of clinicians believe that we really underutilize it, even from a cataract perspective and definitely from glaucoma perspective. And when need be, everybody orders visual fields, so that's that. Next slide, please. So this is what most people who are really doing research, we had a glaucoma myopia center at Singapore National Eye Center. We would sometimes even order MRIs for our patients to detect staphylomas. It's very hard to pick that up clinically. It's very hard to get the scans at the borders from an OCT. B-scan does help that. So sometimes from an ocular shape, from the shape of the eye point of view, we have to get MRIs, but that's only in research setting. It's an expensive test and we cannot employ it in everyday settings. Then there's this talk about what are the changes that happen with axial elongation to the choroid and the sclera. And the point of doing this research is to prognosticate. I have a patient, he's in my clinic, I do one test, and I can tell that patient with confidence, you are going to develop myopic maculopathy. You are going to develop this, or you are not going to develop this. A lot of focus of the research into these modalities is to really have a prognostic value. Right now, we don't have that, but there is growing evidence that we might be able to do that in the future. All right, next slide, please. So this is just an elaboration. Everybody knows we can get enhanced depth imaging of an OCT, and so we can do that when there are longitudinal studies. Longitudinal study means when we follow a patient over a period of time. When the eye elongates from anterior to the posterior, the thickness decreases. The thickness decreases. The vasculature is affected. It happens to the choroid, happens to the sclera as well. Everybody knows about sclera stretch. what is the role and the importance and the significance from a pathophysiology point of view of the choroid. So that's what the researchers are really interested into right now. So that's that. Okay, next slide, please. All right. So now we're going to switch gears to onset and progression. One thing is myopia onset, and the other thing is the progression. So what everybody wants is we can stop the onset. That's what we want. The kid never develops myopia. That's what we want. We will talk about progression. Okay, fine. Well, a kid comes to us and that the kid already has, or the teenager already has myopia. But what we really want is it never happens in the first place. So what we can do from an onset point of view. Now, this onset of myopia, it's highly nuanced. We don't have all the answers. And there are just, so much talk about electronic devices and the differences and how we can measure them and how does an electronic gadget change from the natural sunlight and how does human behavior changes, the usage of screen that has increased exponentially over the last couple of decades and the technologies. So next slide, please. So that's that. Now, okay. So let me go through. No. Go back, please. Back, please. Yeah, there. Okay. So this is a study in the mouse. This is a study in the humans. This is where normally a human eye emetrophysis. This is where it stops. The growth of human eye stops around the age of 11 years. It happens at a different time in mouse, obviously, but that's when it happens in humans. And the height grows because everybody knows most male teenagers, they grow all the way up to late teens. And the axial length of the eye also keeps growing. So the eye is growing, the body is growing, but the people who develop emetropia, that's when it stabilizes. This is what happens normally. This is what's been happening for ages. This is what's been happening since the time of Hazrat Adam. All right? We don't understand this. We don't have all the answers. Let me be very clear about that. We don't have all the answers how this happens. Yes, we understand the mechanisms. Yes, we understand the optics. We will talk about that. But we don't have all the answers. It's an extremely complex process, and we are just beginning to unravel it, how so many factors play their part into it. Next slide, please. So at birth, this is the normal frequency of people with different disorders. This is an interesting one. At 3 months and 9 months, it has been found that people who have really amazing accommodative responses to hyperopia at the even age of as early as 3 months, these kids later on are very good at developing emetropia. This is just stuff from last decade, so it's very recent. It's one thing to fix a problem, it's another thing to just understand at the very basic level. So we're just beginning to understand that there's data, there's evidence that kids, so that's why there's a lot of researchers think that accommodation plays probably a huge part in very early infancy, in very early childhood. Okay, next slide, please. All right. Now, everybody talks about genes and environment, and glaucoma is a multi-genetic disease, and it's very hard to map those genes. There are ways to do that. This is a highly complex topic. I mean, we can just have a couple of talks on this. But as a clinician, when a kid comes to us and we ask that, okay, do you have one parent as a myope? Do you have both parents as a myope? How many family members in your family have myopia? Or nobody in your family has myopia, and today you're 6 years old and you are -2. So what is the risk factor of your sibling? We want to answer those questions from a clinician. It's very hard to do that. So we have these studies, genome-wide association studies, but the data is lacking. It's very hard to do that. We have these factors, polygenic scores and polygenic risk factors. It can only polygenic scores can only answer multivariate diseases up to 20%. That's not clinically significant. But polygenic risk factor can predict up to 80%. That is something clinically significant, and we want that. So that's what we want. Patient comes to us, and we can predict with certainty if he or she will develop high myopia. All right, next slide, please. All right, so how much more time do I have? All right. So there's this huge talk about, there's a discussion about indoors versus outdoor vision and indoor versus outdoor time. Up till now, the data is very robust about the fact that outdoor time is protective against the onset, not the progression. So right now, if a kid comes to us and the patient already has myopia, we would still stress them to have a healthy lifestyle and spend some time outdoors. But we would really tell them categorically that the evidence at present suggests that outdoor time of as much as 14 hours a week or 2 hours a day, it helps and protects against the onset, not the progression. Okay, so that's one thing. Second thing that research is concerned about, what is the difference between sunlight and the light in a closed environment? How does that vary, and how does that affect or increase the prevalence of myopia or even progression of myopia for that matter? What is the role of eye movement? What is the role of these on and off pathways? How do they come and play part in the pathophysiology, in the pathogenesis at a very basic molecular level? And how are circadian rhythms and sleep is involved into that? Next slide, please. All right. So there's strong evidence that over the last few years, and especially over last decade, the ownership of smartphone is increased, and every clinician would just agree to that. Especially in urban environments, kids have their own smartphones now, and doesn't matter what their age is. But we all see that pretty much every day. That coincides with the growing prevalence of myopia as well. Is it causal or not? We don't know that for sure. It's just an observation from cross-sectional studies and even longitudinal studies. Next slide, please. All right. This is the difference. If somebody reads a natural textbook, there's no luminance. But if somebody uses a screen, this is the luminance, the radiance, the intensity of the light that the eyes experience. How does that really play a part in making that eye myopic? We don't have all the answers. There is evidence from animal models which suggests few things, but it's not very clear. The studies are contrary even at times. Mouse, the study says one thing. Monkeys, the study says something else. Okay, next one, please. Oh, the one before that. Yeah, this one. Right. So if somebody reads a natural textbook, this is the spectral peak, something close to the longer wavelengths. Kindle is the only thing that's close to that. Everything else, all the iPads and all the other pads, it's on the bluer side of and the shorter wavelengths. Next slide, please. This just shows that in a different way. And this is the textbook Kindle, and that is the normal, regular iPad or smartphone screen. Next slide. So these smartphones, they have this feature now that because everybody's talking about it, the near work causes myopia. It hasn't been proven in studies, but there are even evidence. Can we go back to that? That there are these features of screen distance that can help. That just reminds a user that okay, you need to make the phone be a bit away from you. All right. So now there are these technologies of augmented reality and virtual reality. So people get this motion sickness. It's usually because of the verges accommodation difference. It's a technical concept, but how there's going to be more use of this technology, and whether that plays its part in myopia or not, we don't have the answers yet. Next slide, please. All right, so this is a robust data from a study. What it shows is that duration of about 14 hours is protective against myopia onset. Anything more than 14 hours, there was a plateau effect. So the cutoff, the authority, this is like first decade of this century. This stuff is really old. It's like 18 to 20 years almost old. So, but we're just starting to talk about it. So as clinicians, we should tell our patients that please make sure that all your kids spend good 14 hours per day in sunlight. A lot of countries have even talked about that, and they have made it mandatory. In Taiwan, they made it mandatory that kids spend 1 hour during their school, and 1 hour, it's parents' responsibility. That's how seriously they're taking this. Next slide, please. All right. This is just a simple mechanism that how we achieve emetropia, how we do that. And we don't have, I'm going to keep saying that, and you might ask me what's the point of this talk if you just say we don't have all the answers. But the point of this talk is to differentiate what we know for sure and what is still being researched, and we might have answers in the next couple of years and the next couple of decades. So this is just a mechanism that just explains us that how these things play. Retinal ganglion cells, their role, the dopamine, which everybody calls the stop signal for myopic growth, the role of nitric oxide. We don't know where it comes from in the choroid, but what is its role and how that translates into the choroidal thickness. And a lot of treatment modalities I will talk about, it is postulated that it is maybe nitric oxide that doing its part, or maybe it's the dopamine that doing its part. And in those, when we do start those patients on those treatments, sometimes we observe choroidal thickness, sometimes we observe spiral thickness. Once we put somebody on atropine, or we put somebody on defocus glasses, or even when we talk about RLI. Okay, next slide, please. This is just so this is the whole spectrum of a normal everyday life, normal sunlight. We don't get this broad spectrum of light with indoors environment. Next slide, please. These are just different light media that we usually encounter only indoors. None of that replicates that of natural sunlight. Halogen bulbs, LEDs, warm LEDs, xenon bulbs, incandescent screens. It's totally different from that of sunlight. Next slide, please. There's even talk about longitudinal chromatic aberration. In an hyperopic eye, the shorter wavelengths focus on the retina. In a myopic eye, the longer wavelengths focus on the fovea. Up till now, there was this concept of foveocentric human emetropization. Data back in 2010 made us realize that that's not how eye works. Eye works as retinocentric. It takes input signals from the whole of the retina, even from the periphery, and that's how the signals to become emetropic are derived. Next slide, please. All right. So this is a distant environment. This is the dioptric power we need to look at far. It's a flatter environment. There is broad spectrum of light exposure, and that's what we need. In a close environment, this is the dioptric range we need. It's not a flat dioptric environment. Next slide, please. Same thing. We look far, we don't need. We look close, we need a lot of that. The dioptric range and the power and the defocus. Next slide. All right. I'm going to spend a couple of 1-2 minutes over here. So far, data has quite remarkably explained that there are these on and off bipolar cells. So light comes, all the way to photoreceptors. They get hypolarized, signal gets transmitted to the bipolar cells. Now, these bipolar cells, some of them are on and some of them are called off bipolars. The on ones have their own receptors and the off ones have their own receptors. This is an on receptor, this is an off receptor. These on bipolars and off bipolars, they sometimes go and even what we call intrinsically photosensitive retinal ganglion cells. These RGCs, these retinal ganglion cells are different from the routine ganglion cells that we all know, that we all care about from glaucoma and all other diseases. This is different. These pathways, they help the human eye appreciate the brightness of natural environment. It has been found that the on signal, which is stimulated by broad sunlight, and dopamine is involved over here, it acts as a negative feedback mechanism. The growth of the eye stops. They have done experiments with many animal models, many mammals, and it has been repeatedly found that if there is more stimulation of on pathway, we can do that even with ERG. There are some diseases as well. Congenital stationary night blindness diseases don't have this, and most inherited retinal diseases, myopia is a finding. So this pathway, and we just know this, but we don't know that how it helps with other factors like accommodation, factors like peripheral defocus, and what happens once the myopia kicks off. Once the myopia kicks off, we know what happens to the on pathways. The signal goes down. Can we fix it? Is it as a result or is it still the cause? We don't have the answers to that. But the pathways has been found, and there's a lot of ongoing research to how we can clinically target this. Okay, next slide, please. All right, I'm going to just spend the last couple of minutes about just few pathogenesis mechanisms. Myopia is a very old disease. The word myopia comes from Greek, and Aristotle was the first one to mention it. The evolutionary pathways of emetropia are robustly intact throughout mammals, which is amazing. It's amazing because even though it's been there for so long, we still nobody bothered. There's so much research going on over the last few centuries, but how human eye and other mammalian eyes achieve emetropia, it's really amazing. And we're just beginning to unravel that. There are many optical mechanisms involved. There are many open and closed loop mechanisms involved. The optics of the eye and the characteristics before, during, and after the myopia, how they all play. It's a complex phenomenon. Next slide, please. Yeah. So we have been here for millions of years. Primates a bit earlier than the rest of them, but it's the pathways for emetropia in those. There are many animals out there which don't even have a fovea. Even they achieve emetropia. How does that happen? And it is believed that those pathways, evolutionary pathways, are just intact throughout the animal kingdom. Next slide, please. This is what happens in normal emetropia. The eye elongates as much as 5 millimeter from birth all the way up to the age of, like I showed you before, 10 years. Once the eye elongates, naturally the eye should become myopic, but that does not happen. Why? Because the cornea flattens. That also does not happen. Why? Because the lens also flattens. This corneal flattening and this lens flattening, it is happening at the same time, and it is highly and precisely regulated. Even right now, all over the world, most humans are emetrope. And the reason they're emetrope is because of these mechanisms. Even when the eye is elongating over good 8 to 10 years, the lens is flattening. the cornea is flattening, so that optical power just by elongation is countered by lens, by the reduction of power in the lens and by the reduction of dioptric power of the cornea. And from a clinical perspective, we know that sometimes, we see, oh yeah, it looks like a myopic eye. We do the axial length, it's like 24 or something. But the corneas are really flat. It's like 38 or 40 diopter cornea, and the patient is emmetrope. The patient never put on any glasses throughout their whole life. Okay, next slide, please. All right. So for an emmetrope eye, the growth stops. All right. But for a myopic eye, after this point, it has been found. This is done in US. This is done in US. This is done in Singapore. But what they found was when people had clinically obvious myopia, when it was kicked in, minus 0.5, minus 0.75, the axial length was 23.8 millimeters. The axial length was 23.8 millimeters across totally different ethnic populations. Next slide, please. All right. Same thing. Axial length was about 23.8. So over here, we start off here. Every eye starts off hyperopic. Comes over here, emmetropes. Either it stays there or it goes on to become a myopic eye. What happens here and what happens here? These two inflection points. Those are the hot topics. That's what we want to unravel. So that even from here, when eye is over here, is trying to stay emmetrope. Okay, the eye is elongating. The corneal power is flattening. The lens is flattening. The eye is trying its best to stay emmetrope, but some eyes go on to become myope. What is happening? Maybe we can make some intervention over here. Definitely at this inflection point. Same thing over here. So these eyes, they go on to become myope, and over here, this is where the emmetrope eyes continue. Myopic eyes continue downhill like that. Next slide, please. Okay, so this is just a very. I just put this picture over here just to make us realize what they're trying to do to understand the whole cascade. Light comes here, goes to the photoreceptors, goes to the on and off pathways, goes to the brain, what happens to the signals, how they're trying to map it all so that where we can make some clinical interventions. Next slide, please. All right, these concepts of rod and cone ratio, the concept of small, medium, large cones, and how their population, when we move away from the fovea, they knocked out fovea in animal models, and the eye still kept on becoming myopic in the presence of myopic stimulus. So how does that play? How the eccentricity, when we move from 0 degrees to 30 degrees, temporally or nasally, how does this interplay between rods and cones into the pathogenesis and eventual development of myopia? Next slide, please. How much time? Sure. This is just a humble request to everybody who is logged in from the Zoom platform to make their mics and cameras off. They have to do it manually. I can continue? Okay, sure. All right, this is interesting data. They spread this point blur. In myopes, it's vertical. In hyperopes and in emmetropes, it's almost horizontal. This is just in relation to the last part that I said, that when we move from the fovea and all the way to the periphery of the fovea, this is what happens in a myopic eye. Next slide, please. Same thing. Myopes, it's vertical, and hyperopes and emmetropes, it's slightly along the horizontal sides. Okay, next slide, please. Yeah, here. Same thing, on and off pathways, there are many nuances over here. This is not from an animal model, this is from a mouse model. There are many nuances. How the receptors come into play. What is the association of these on bipolar cells to other dopaminergic amacrine cells and to the rest of the retinal environment and to the rest of the direction sensitive retinal ganglion cells and starburst amacrine cells. Next slide, please. Okay. All right. So I've pretty much talked about this. It's not just one thing. We cannot just say it's just time outdoors. We cannot just say that it's accommodation. We cannot just say that it's near work. It's a combination of so many factors. We cannot just say it's just peripheral defocus because sometimes there's conflicting evidence. So the only logical conclusion from everything is it's everything. All these factors come into play to make a myope emetrope versus to make an eye emetrope versus a myope. Now we need robust eye models to test these hypotheses to understand the interplays. The problem with research is on a disease like myopia is something we do it on animals, we do it on mice, guinea pigs, monkeys, but when we try to replicate that in human eyes, sometimes it works, sometimes it doesn't work. And a lot of times we cannot even do stuff in human eyes, which is just unethical. So that's having a robust eye model where we can test hypotheses, that's another thing. And then the concepts of ocular optics, photoreceptors, peripheries, all these factors that I just mentioned briefly in the last few slides. Next slide, please. Yeah, so on-off pathways, dopamine, and which is the agent in the amacrine cells, and the intrinsically photosensitive retinal ganglion cells. Their role and how we can clinically modulate their roles. That's the areas of interest so that even if somebody has myopia, we can do something about it. Or we can come up with robust data to say something like pre-myopia. Like we have it in the patient comes, we just do hemoglobin A1C, we get a result, we tell that patient, okay, you are pre-diabetic. Just one test. How we can do something like that with the human eye? Just one test, something simple, we do some levels, and we can say with certainty you're in that state, let's put you on this so that the eye becomes emetrope in the future. So that's the effort. Next slide, please. The role of RP, choroid, and sclera. It is still extremely. We understand what happens to RP, choroid, and sclera once the eye is already myopic. We definitely understand what happens in high myopia, people who are more than -5 or -6 diopters. But what we don't understand is how these mediators, all trans, retinoic acid, adenosines, and the nitric oxide, where do they come from? And how can they be clinically based even in the form of drops or something like that? We can come up with formulations so that we can address and give a therapeutic answer to the problem, and the role of circadian rhythms in the growth of the eye. There is diurnal variation in human eye growth. There's evidence of melanopsin and its role in the on pathways and all of that. How we can do that? We understand that the circadian rhythms in modern lifestyle in urban environments, it's totally disrupted. It's not the case 50 years ago where people would just sleep at night and work during daytime. That also has public health implications. There are many people who have to do night jobs and night shifts. How does that encounter? What can be healthy cutoffs and standardized protocols that can be dished out to academic centers and and made part of national health policy, eye health policy, stuff like that. That's about it. I can just recap that it is a growing disease, and we need to have a national formulation of policies and perspectives. It's a highly complex phenomenon. We're just beginning to unravel it. We need to have robust evidence about onset and progression. We can do stuff about onset, we can do stuff about progression. That's the second part of this talk. But the whole point of this talk and exercise is to just put the word out that it's a disease. Myopia is not something that you're just born with it, or you just get it because your parents had it, or because everybody is getting it. We need to take it seriously. We're academic clinicians. We need to have robust evidence when we talk and we have these chair talks with our patients. We should just tell them what we know for sure, and we should tell them what we are, still working on it. That's about it.
So far, any questions? Because I think first part of our presentation, and we have a 10 minutes tea break. After that, we'll resume with the second part of treatment and biopropagation. Thank you. Please,
There's a 10-minute break, and we'll resume with part two, myopia dissolution. So please follow.
You have said in the slide that outdoor activity 2 hours a day
Yes.
is protect in the onset, not on progression.
Yes, we don't have evidence for that. It's very clear.
But later on, you have told there is a on bipolar cells.
Yes.
And they receive the light.
Yeah. So
and they
exactly.
they inhibit the elongation.
Exactly.
So